Hello, good afternoon. My name is David Webb. I'm a consultant endocrinologist at the University Hospitals of Leicester NHS Trust, and I also work within the Leicester Diabetes Centre as a senior lecturer in diabetes medicine. I'm going to talk to you today about the very important microvascular complication of neuropathy. Neuropathy can be defined as any structural or functional damage to peripheral nerves as a result of elevated blood glucose concentration in a patient with diabetes or impaired glucose regulation. There are many different forms of neuropathy, as we will see in this talk, but I'm going to focus in particular on probably the most common and probably clinically important conditions of distal symmetrical polyneuropathy or DSPN and autonomic neuropathy or AN. The aims of this talk, therefore, are focused upon giving you a clinical oversight of DSPN and AN in particular, and in particular to form appropriate strategies to assist people with diabetes to manage neuropathic pain appropriately, because this is known in certain circumstances to be an extremely debilitating and difficult condition to live with for people with diabetes. But I'm going to begin this talk by providing a short but I think relevant recap of some neuroanatomy, and also mentioning, if only briefly, a couple of other forms of neuropathy other than DSPN and AN. So this is a short neuroanatomy recap of the peripheral nervous system. You can see that the peripheral nervous system basically consists of any nervous tissue which is situated outside of the spinal cord or brain. So, for example, the somatic nervous system consists of afferent nerve fibers which travel from the sensory organs which allow us to feel pain, temperature and touch. These impulses travel along these nerves to secondary projection neurons in the spinal cord, and then subsequently, after having been processed by our central nervous system, they then travel via efferent nerve fibers to skeletal muscle to action voluntary movements. Another important aspect of the peripheral nervous system is, of course, the automatic or autonomic nervous system, which is involved with homeostasis of all sorts of body functions, but are not under our conscious control. So these would include functions such as heart rate, blood pressure, erectile function, but there is a whole gamut of important functions which we obviously have no voluntary control over, and which have nerves travelling out with the spinal cord or brain. And these are important to understand because it's these particular nerves which tend to be affected by diabetes and the metabolic processes associated with it. So let's consider the spectrum of neuropathy first of all. So as I said, we're going to concentrate on DSPN and autonomic neuropathy for the majority of this talk, but for the purposes of completion, what I am going to do is mention three other conditions which we do see in people with diabetes and are worthy of mention. So first of all, the next couple of slides we will talk about carpal tunnel syndrome, the classic entrapment neuropathy, but there are others also in diabetes. But for this particular slide, I would like to draw your attention to mononeuritis multiplex and amyotrophic proximal motor neuropathy. So mononeuritis multiplex is a relatively rare condition characterized by an asymmetrical, often painful sensory motor loss in at least two nerve areas which are completely independent and not connected with one another. In my practice, and I think in the practice of most UK centres, the development of neuropathy with this slightly atypical pattern would warrant referral to a neurologist to exclude alternative causes such as pro-inflammatory or underlying neoplastic or autoimmune-based disease. Also worthy of mention is amyotrophic proximal motor neuropathy, which, although much rarer than its distal sister condition, is also an important condition and is seen in people with diabetes. Amyotrophic, as the word suggests, is associated with mostly motor issues, and patients most classically will present with motor symptoms such as wasting, weakness and muscular pain, but over the proximal lower limb areas. This condition can either be unilateral or bilateral, and again is quite tightly linked to glycemic control and duration of diabetes. So that gives us an overview of some other neuropathies and gives us now the opportunity to concentrate on DSPN and AN for the remainder of this talk. Epidemiology studies of diabetic neuropathy tend to give divergent results indicative of underlying frequency, prevalence and incidence, and there are a number of reasons for this. For example, the methods of assessment of neuropathy tend to vary and are quite subjective. The patient population will vary according to the underlying study conducted and will therefore also determine the underlying frequency of neuropathy. And also the severity of neuropathy can also be an important and very subjective thing for an accurate assessment of frequency of neuropathy in such studies. Demonstrated here is one of the original and probably more robust epidemiology studies of neuropathy. The Rochester Diabetes Neuropathy Study was a cross-section and longitudinal assessment of some 65,000 patients with type 2 diabetes and was conducted in the United States in the early 1990s. And around 2/3, over 60% of patients with either type 1 and type 2 diabetes had some form of neuropathy documented as a result of this particular study. And the assessments of neuropathy were performed by mainly quantitative assessments via nerve conduction studies and questionnaire-based assessments. Importantly, around 10 to 15% of patients had some form of neurological deficit attributable to non-diabetes causes, and this is important when thinking of patients who are presenting with possible symptoms of DSPN in our clinic. Of the 2/3 of patients with diabetes who had objective evidence for some form of neuropathy, only about 20% of them actually knew they had it and exhibited symptoms of it. Another important point when it comes to the potential implications of and protective factors that we need to consider when treating people with DSPN and neuropathy. Turning to the pathogenesis of the disease. So, as with most microvascular complications of diabetes, the underlying cause of neuropathy or nerve damage is poorly understood. What we do know is that hyperglycemia and probably other factors are involved in damaging the underlying microvasculature and capillary blood networks supplying these tissues. Subsequent mediators of oxidative stress, endothelial dysfunction, and inflammatory markers probably are responsible for damaging these capillary networks, which eventually result in local hypoxia, and in the case of peripheral nerves, neural hypoxia. Unfortunately, these tissues appear to be relatively susceptible to this type of damage and lack very good capacity to regenerate, hence making this a potentially quite irreversible disease once it occurs. So In summary, as regard to pathogenesis, as far as our current understanding is concerned, a combination of factors surrounding oxidative stress and pro-inflammatory factors associated with metabolic and endocrine disease result in damage to capillary and arterial networks supplying these tissues to cause an underlying microangiopathic process, which subsequently essentially starves the tissue of underlying nutrients and causes damage to the vital tissue. This so-called unitary hypothesis unifies our understanding really of all microvascular processes in diabetes as far as the current understanding is concerned. So as I said, it is, I think, important in any talk about neuropathy and diabetes to consider the classic entrapment neuropathy of carpal tunnel syndrome. Illustrated here is a slide demonstrating really how this occurs through compression of the median nerve at the level of the wrist. This again is thought to be due to the accumulation of glucose and glucose attachment to proteins in the matrix of the tendon, which essentially increases its size and compresses the underlying nerve. Symptoms can be very variable with carpal tunnel syndrome, ranging from vague tingling and numbness at night all the way through to an excruciating pain and loss of complete function of the median nerve. It is, of course, very important to take these symptoms seriously and to perform the necessary investigations such as nerve conduction velocity studies in these patients because this disease can be progressive, can cause permanent damage to the median nerve and is eminently treatable. So let's consider some general aspects of DSPN. The commonest form, as I've said, of peripheral neuropathy in diabetes is this distal symmetrical polyneuropathy. It's defined as the presence of symptoms and or signs of peripheral nerve dysfunction when we've excluded other causes. As we've suggested, DSPN is often asymptomatic during its initial phases, but is a major cause of underlying foot alteration and amputation in people with diabetes. Just returning to epidemiology briefly, so we can see here a recent publication in Diabetes Care really confirming previous epidemiology assessments in confirming really that it's the duration of diabetes which is the important thing in determining the underlying frequency of the disease. Risk factors for DSPN, well, hypoglycemia, of course, is one of the major independent risk factors for the development of any microvascular complication of diabetes. But interestingly, neuropathy in particular appears to be independently also associated with other risk factors which we more commonly associate it with cardiovascular disease. For example, hypertension, dyslipidemia, smoking, and microalbuminuria are all risk factors for the development of DSPN as well as hyperglycemia. And of course, the non-modifiable risk factors, age and duration of diabetes, are also major contributors. This slide I put in just to illustrate the range of symptoms that people can describe when they have symptoms in their feet. These range from symptoms which are suggestive of burning through to symptoms which are suggestive of temperature reduction and coldness in the feet. Classically, some people also describe a feeling of walking on cotton wool, and symptoms can actually be relatively non-specific in nature. Just to remind ourselves of what allodynia is, this is a commonly used term which is used to describe symptoms, excruciating symptoms of pain, mostly associated with a stimulus which shouldn't normally be associated with pain. We also commonly seen in clinical practice, although don't really understand the underlying pathogenesis driving it, a differentiation between different forms of DSPN. So we not uncommonly, particularly in relatively young patients, perhaps with type 1 diabetes, see acute sensory DSPN, which is associated with really quite debilitating and severe pain symptoms. This is often characterized as by lower limb bilateral severe burning pain, aching, and it can be so severe to cause quite profound weight loss. Other diabetes-related complications are relatively unusual in this group, and much like any acute and then chronic remitting disease, the symptoms tend to settle down within 6 months. This is differentiated slightly from the more chronic and classic picture of sensory motor DSPN, whereby there is a gradual onset of symptoms and patients will describe the more classic paresthesia or perhaps burning sensation at night associated with a glove and stocking distribution. These individuals clearly are at high risk of underlying foot ulceration. And that brings us on to the consequences of DSPN. Well, of course, I don't need to tell this audience of the risks associated with this disease. It is a major risk factor for the development of diabetic foot ulceration, amputation, and of course Charcot's arthropathy, which warrants a talk under its own right. But unfortunately, we don't have time to go into the importance of this disease here. Suffice it to say, it is clearly associated with diabetic neuropathy. Also listed here, I think, is the increasingly important condition of ataxia or coordination associated with diabetic peripheral neuropathy, perhaps slightly overlooked, but increasingly important as we see an association with people with diabetes increasing into elderly ages. Falls are not uncommonly associated with loss of proprioceptive function and also ataxia associated with peripheral neuropathic processes, and diabetes is no exception to this. Just to illustrate the really importance of foot checks and surveillance to reduce the risks of diabetic foot ulceration in people with neuropathy, there is lots of epidemiology evidence to link this, and this is just one community-based study, the Northwest of England Diabetes Foot Care Study, which looked at the incidence of and risk factors for new diabetic foot ulceration in a community-based patient cohort. And it can be illustrated here that more than 2% of community-based patients will develop some form of foot ulceration each year. And therefore, this promotes the use of neuropathy disability scores, 10-gram monofilaments, and regular palpation of foot pulses as recommended routine practice and screening tools for healthcare professionals in general practice. Assessment of DSPN. Well, the assessment of proprioception is, of course, most commonly still used uses a tuning fork in clinical practice, which tests vibration perception. The monofilament 10-gram monofilament screening test is also, I think, probably the most widely used assessment for peripheral sensation. But then more formally, nerve conduction velocity measurements can be looked at and requested in order to look for particular large fibre neuropathy. This slide simply illustrates some common tests used in the assessment of neuropathy. As we can see here at the top is nerve conduction studies. This is the gold standard test for DSPN and is a sensitive and specific tool and is highly reproducible. It, of course, though, does require a trained professional in order to both do and interpret the test. Other tools which are commonly used, of course, neuropathy disability scores. As with any questionnaire-based study, it's susceptible to sensitivity and specificity issues, but is obviously a much easier assessment to perform. And then more specialist techniques which are available in some centres in the UK include skin biopsy studies in which the intraepidermal nerve fibre layer density is assessed after having performed a skin biopsy. This is obviously an invasive test and has all the associated risk factors associated with breaking the skin and taking a sample. But this probably is one of the more accurate and quantified assessments of underlying small fibre dysfunction. And then in some centres, increasingly emerging as more of a clinical rather than research tool are emerging techniques such as corneal focal microscopy, which again correlates the nerve fibre layer in the cornea with the intraepidermal assessment of neuropathy. So in summary then, clinical examination for DSPN would involve a assessment of vibration sense using most commonly a tuning fork or some other vibration sense tool. Of course, there will be evidence of glove and stocking loss, which can be picked up with blunt things such as a pin prick, but perhaps more accurately, and what is recommended for use in most clinical guidelines is a 10-gram monofilament test with 12-point discrimination. And I think certainly in our practice, we would advocate that some form of diagrammatic illustration of this is performed to enable assessment further down the line for comparison purposes. So I won't list all of the things to look out for on this particular slide, but to suffice it to say, an important aspect of care for anybody with diabetes is a regular foot check, and listed here is the common things that perhaps any clinician would be looking for to look for evidence of both vascular and neuropathic integrity. So as we said, there was quite a significant proportion of patients who are picked up in epidemiology or observational assessments of neuropathy in whom the underlying cause of neuropathy isn't felt to be diabetes related. And that's why it's always very important to exclude other causes or contributory causes to DSPN in these patients. And for example, other metabolic diseases such as vitamin B12 deficiency, hypothyroidism and alcohol disease are important, but also this can also be associated, particularly if it's a relatively atypical pattern of symptoms and signs due to alternative diseases such as pro-inflammatory, demyelinating or even neoplastic disease. There are also, of course, a whole list of medications which can be associated with potentiating neuropathy. In terms of management, of course, most consensus guidelines will advocate tighter glucose management to reduce the risks of progression of neuropathy, and that's certainly important, particularly in type 1 diabetes, where there is quite good evidence from studies such as the Diabetes Control and Complications trial, whereby there was a significant reduction in neuropathic outcomes in individuals who were intensively insulin treated after 5 years. There are also other studies, particularly in type 1 diabetes and observational assessments, which have shown a good correlation between good diabetes control and the future risk of or progression of neuropathy. The picture isn't quite so clear in type 2 diabetes, however, in terms of glucose management alone, with evidence being relatively limited in terms of its true impact on neuropathic outcomes. Now, this may well be due to the methodological issues of actually defining and measuring neuropathy that we've spoken about already in this talk. But there is relatively little evidence that very strict diabetes control in individuals with type 2 diabetes for quite some duration has that much impact on neuropathy outcomes. There is certainly evidence also that a more multifactorial approach, however, perhaps both with antihypertensive treatment and dyslipidemic treatments, the sort of management that probably we would be aiming to achieve in most people with diabetes to reduce the risk of cardiovascular diseases is certainly important as well to microvascular outcomes, including neuropathy. So, in summary, assess level of blood glucose control and blood glucose profiles and act accordingly. Aim for optimal stable control, and in those individuals who are symptomatic and with painful neuropathy, there is obviously pharmacological options. Of course, advice and protection is key here to reduce the risks of neuropathic ulceration. So educate your patient, regular shoe and foot inspection, appropriate footwear to avoid tight-fitting shoes and padded socks, to give the patient a monofilament if you have access to them, advice using a mirror on the floor of the bathroom, or advice over heat, cold, injury exposure are all important are important aspects of care. There are also some non-pharmacological treatments which may help with symptomatic or painful neuropathy, none of which are massively evidence-based, but nonetheless may have a place in management. So what about drug treatment for DSPN? Of course, here we're not talking about prevention of neuropathy in the first place. As we discussed, the underlying pathogenesis of the disease is such really that once damage occurs in the peripheral nerves, it's quite difficult to completely regenerate this, and therefore metabolic control and glucose lowering has a place in the prevention of progression of disease. Here we're more concentrating on that proportion of patients who complain of positive symptoms, that is pain, associated with DSPN. And there are a range of drugs which have been available for use for these occasionally debilitating symptoms, and they've been useful for some of them for many years. Tricyclic antidepressants being the classic example, going through to SSRIs, anticonvulsants, drugs which have a history in treating cardiac arrhythmias, right through to opioid-based analgesics. So illustrated here is just some recognized drugs which are used throughout the world in neuropathy and their drug doses. In the UK, we have a nice National Institute of Clinical Excellence guidance for the treatment of painful DSPN. First-line treatment now is the SNRI duloxetine, essentially because it's associated with fewer side effects than amitriptyline. Amitriptyline is now more confined to second or third line therapy. If first-line treatment was with duloxetine, it's recommended to switch to amitriptyline or pregabalin, or combine one of those two agents with pregabalin. It is recommended in the UK that failure to control symptoms with those three drugs, or two in combination, should warrant a referral to a pain service and it isn't recommended that prolonged courses of opiate-based analgesics are used under these circumstances. Recent advances. Recent advances in this area are relatively limited. There are a number of most of these drugs have been subject to relatively small scale randomized controlled trials with systematic reviews and network meta-analyses of this particular data, really suggesting that most medicines are effective at reducing pain scores for short-term management of painful diabetic neuropathy, although our ability to be able to differentiate the efficacy of one compared with another in this respect is relatively limited. And I think it's fair to say really that progress in this area and in neuropathy research in general has been a challenge over the last 20 to 30 years. Here are some examples of emerging treatments for painful DSPN, and they range from some quite familiar agents perhaps from the past, such as capsaicin, a dermal patch though in this case, through to other perhaps more modern forms of anticonvulsant therapies such as lamotrigine, through to again perhaps more controlled use of tramadol, but also some quite novel anti-inflammatory approaches too. So I'd now like to spend the last 5 minutes or so talking about another very important peripheral nervous system dysfunction associated with diabetes, and that's diabetic autonomic neuropathy. As we've said, the autonomic nervous system is involved in involuntary control of various bodily functions, and can be further subdivided up into the symptomatic and parasympathetic nervous systems. I won't go into details over the differentiation of the function of these two, but they tend to be they tend to produce opposite effects to one another. Why is it important to recognize diabetic autonomic neuropathy? Well, because it appears to be a major signal that there may well be associated quite serious cardiovascular abnormalities associated with the disease. It's estimated that around 25 to 50% of patients will die within 5 to 10 years of a diagnosis of autonomic neuropathy, and that the 5-year mortality rate is some 3 to 5 times higher than a patient with diabetes but no evidence of DAN. It is clearly and therefore a marker of adverse cardiovascular, renal and cerebrovascular outcomes. What systems are involved in the autonomic nervous system? Well, as we've said, these the function of the autonomic nervous system covers most bodily organs. The most severely affected nerve tends to be the parasympathetic vagus nerve, but the effects tend to be widespread, but can also be related to a single body system. The ones which I'm going to concentrate on here are of course cardiovascular, gastrointestinal and genitourinary. So let's turn briefly to the cardiovascular autonomic dysfunction, or CAN. It tends to be associated with impaired heart rate variability, resting tachycardia, but also from a clinical and functional perspective, can also be associated with quite significant orthostatic hypotension and also postprandial hypotension if it's associated with some splanchnic nerve issues. The evaluation of cardiovascular autonomic neuropathy tends to be with some quite sophisticated heart rate variability spectral analyses, and there are pharmacological measures which again have been relatively small scale, but do so show some benefits in some of these measures. Perhaps the most well-known autonomic dysfunction associated with diabetic neuropathy is gastrointestinal clinical manifestations such as gastroparesis. This is, of course, a condition which is commonly associated with impaired vagal function, whereby there is a reduction in the ability of efficient transit through the stomach in people with diabetes, resulting in symptoms which can include early satiety, fullness, bloating, all the way through to quite intractable vomiting and problems with the upper GI system. This clearly is a major issue for somebody with diabetes, particularly someone taking insulin, who has to be absolutely sure that the intake they are consuming is going to be absorbed. There are other gastrointestinal manifestations of this disease, though. For example, esophageal dysmotility, relatively common, and needs to be distinguished really from common or cardinal GORD. However, frank dysphagia is relatively uncommon. Enteropathy associated with both constipation and diarrhea, and at its worst, fecal incontinence. So turning to gastroparesis in a little bit more detail, the clinical presentation of this condition is classically, as I've said, is associated with bloating, early satiety and postprandial fullness, but also dyspepsia and so-called brittle diabetes, as the absorption profile of carbohydrate can be affected by these conditions. The clinical evaluation, again, should involve an assessment of underlying drugs which may be involved with affecting gastric motility. Endoscopy should also be performed. There's an important need to exclude alternative factors which may be causing these symptoms. Metabolic evaluation is also important to exclude underlying thyroid disease, for example, or other urine electrolyte abnormalities which may be contributing to these gastrointestinal symptoms again. Underlying treatment is with antiemetic therapies such as metoclopramide and domperidone, and often the macrolide antibiotic erythromycin also has been shown to increase transit time in gastroparesis. Other clinical manifestations: neurogenic bladder, decreased bladder sensation, hesitancy, and potentially increased risk of urinary tract infections are associated with this disease. Erectile dysfunction, a very important and quite common problem in diabetes, and but also not forgetting there is an element also of female sexual dysfunction associated with autonomic neuropathy. There is also certainly an increasingly accepted phenomenon whereby hypoglycemic unawareness in some way is linked to the neuropathic process associated with underlying diabetes, but also a commonly described problem in patients with often long-standing diabetes is pseudomotor problems as well, with either reduced or excess sweating and gustatory issues as well. So that leads us to conclude that DSPN is a common and heterogeneous complication of diabetes whose frequency and severity are linked to disease duration. Effective treatments to reverse or even halt progression of DSPN are limited to prevention of recognized risk factors and have limited efficacy, particularly in type 2 diabetes. Better, less subjective endpoints for clinical trial interventions are needed, and treatments are available for painful DSPN, but are associated with significant side effects. So at present, the underlying treatment rationale in terms of achieving good glycemic control and other cardiovascular risk factor control are paramount at trying to reduce progression of the microvascular complications, including neuropathy, but also then in establishing education and reducing the risk of further complication, and in particular diabetic foot ulceration is of paramount importance in patients with DSPN. Thank you for listening.